Thank you very much for this opportunity today to talk to you all associated with the National American Indian and Alaska Native Mental Health Technology Transfer Center Network. I'm going to be talking about the effectiveness and utilization of telebehavioral health. The future is now. My name is Nancy Roget, and I'm the Executive Director for the Center for the Application of Substance Abuse Technologies. And the director of the National Frontier and Rural Telehealth Education Center, and the co-director of the Mountain Plains ATTC. I'm very excited to be with you today and to have this conversation about one of my favorite topics. I am speaking for the Mental Health Technology Transfer Center Network, and this webinar is sponsored by the National American Indian Alaska Native MHTTC. It's a program funded by SAMHSA. So this is what I'm going to talk about today. I'm going to talk about the uptake of telebehavioral health. I'm going to talk about the research base for telebehavioral health in terms of mental health services, substance use disorder treatment services, findings from systematic reviews, what clients and patients think and feel about telebehavioral health, what clinicians think and feel about telebehavioral health, some guidelines and tips, privacy and security issues, and including 42 CFR Part 2, resources that are available for folks to access, and then looking to the future, the post-public, meaning post-public health emergency, and then a summary. So let's get started. When we talk about making the case for telebehavioral health, there's a really nice definition which Don Hilty came up with, and basically it says telebehavioral health in the form of synchronous, meaning live, video and audio is effective, it's well received, and it's a standard way to practice. And certainly since the onset of COVID-19 pandemic or public health emergency, we've seen this rapid virtualization of behavioral health services. And in fact, we're starting to track some of that data. A recent study, 2 different studies that were done. Prior to the pandemic, about 9% of patients' interactions for the surveyed practitioners was via telehealth. But during the pandemic or during the quarantine, 51% of services were delivered via telehealth, and it's expected that that practitioners will continue to provide services via telehealth about 21% of the time. In another study, this is of Medicare primary care visits, and this is by Medicare primary care providers. Prior to the pandemic or public health emergency, less than 1% of folks were primary care practitioners were providing services via video conferencing. During the pandemic, in all states, it averaged about 43.5%. And what they also saw from this study is that providers in rural counties had smaller increases in Medicare primary care telehealth visits compared with providers in urban areas. So certainly with primary care, we've seen a great uptick during the public health emergency in the use of telehealth. Another study that was done recently, this came out in August, did a survey of 2,000 clinical psychologists across the United States. And this is what they found. Prior to the public health emergency, psychologists performed about 7% of their clinical work virtually. The use of telebehavioral health increased 12-fold to 85.5%, with 67% or over 2/3 of psychologists conducting all of their clinical work using telebehavioral health. And psychologists projected that they would perform a little over a third of their clinical work via telebehavioral health after the pandemic. So we can see sort of this general great uptake in the use of telebehavioral health, certainly during the pandemic. So great increase, and then less of an increase or a decrease. People are predicting post-pandemic, but of course we're not close to into the pandemic yet. So what is the research base for providing services via video conferencing or telebehavioral health? And you'll hear me use 3 different terms, and I'll use them interchangeably. I'm trying to use the term telebehavioral health because it also includes not only mental health, but substance use disorder treatment services. But I'll use telehealth, telebehavioral health, and video conferencing sort of all together. So what's the research base for telemental health related interventions? Okay. And what I can tell you is that it's over 60 years old. And in 1959, the University of Nebraska was one of the first institutions to begin using video conferencing platform to deliver education services, research, consultation, and actually treatment. And they were one of the first folks to do group counseling online. And then also, if you look at the literature, there was a telemedicine clinic at Boston Logan Airport in the 1960s. And they they were able through telehealth to share information about patients from one provider to another. And this was at the airport to deliver services to Massachusetts General Hospital. And you can see this is an actual picture from this particular service delivery in Boston. So there's a ton of literature that shows the evidence for video conferencing in delivering mental health services. And these are just examples of some of the seminal systematic reviews that have been done by researchers looking at what is the literature support for the delivery of services, mental health services, using a video conferencing platform, and it's very substantial. Regarding the video conference or the amount of literature support or research support for video conferencing for substance use disorder treatment services, what we can say is that the amount of research is increasing and it's getting more rigorous. And it's focused in, when we look at the literature, we can see that it's focused on opioid treatment and also alcohol treatment. And Lynn in 2020 just did the most recent systematic review of the literature regarding providing services, SUD services via video conferencing. So let's look at some of those systematic reviews. This is a systematic review that was done by Battistini and colleagues in 2015. And she looked at research articles regarding providers offering SUD treatment services via video conferencing. So SUD treatment providers, and then also services that were provided, mental health or behavioral health services that were provided in jails and prison. And here's 2 of the takeaways from her meta-analysis. So being physically present in the room with a client doesn't appear to be necessary, and that you can, in order to develop a effective therapeutic relationship, and that you can do assessments and gather accurate information from a patient using video conferencing. And the use of video conferencing alone doesn't seem to inhibit clients' willingness to participate or engage in treatment services. So the other systematic reviews, if you boil down what they found, here's the best arguments that we can see from the literature. One is that video conferencing is easy to use. It improved outcomes in communication, and it improved medication adherence. It also decreased appointments, missed appointments. It decreased wait times for patients getting into treatment. It decreased readmissions, so it helped patients stay engaged, and it decreased patients' travel time. So here's some other findings. Telebehavioral health is not more expensive than face-to-face delivery of mental health services, and telebehavioral health is actually more cost-effective in the majority of the studies reviewed. And when we think about this, certainly the cost of equipment in the last 5 years has come way down, both for the treatment centers, or the people delivering services, as well as for patients and clients. Patient appropriateness for video conferencing. To date, no studies have identified any patient subgroup that doesn't benefit from or is harmed by mental health care provided through remote video conferencing. All right, and I'll talk a little bit more about other specific populations. Before providing telebehavioral health services, though, clinicians should consider a patient's cognitive capacity, their history of cooperativeness with treatment professionals, their history of violence or self-injurious behaviors, along with access to emergency medical services, support system and a patient support system and its efficacy, and current medical status. So while we make the comment that says, hey, no, almost all patient populations can be seen via video conferencing, there's some things that we need to take into consideration that we need to check regularly. So the patient's cognitive capacity, the history of cooperativeness, what's their history regarding violence or self-injurious behaviors in case we have to contact emergency medical services, what's their support system like, and what's their current medical status. Jay Shore went on to say, yes, you have to do those things, and it's an essential practice, or considered an essential practice, that clinicians assess a patient's comfort level with telebehavioral health on a regular basis regarding both clinical issues, their changes in condition, and their living arrangements. So on a regular basis, and when I talk about tips, we'll get into that in a little bit more detail, but we have to make sure that we check in with patients. Do their clinical issues allow them to receive services via video conferencing? Have they had some severe changes in their mental health or substance use disorder conditions? And what's their living arrangements? And are they able to have some kind of privacy in order to receive services? So let's talk about telebehavioral health clients and clinicians. Well, for some patients, services delivered via telebehavioral health really provide feelings of safety and control. And that's especially true with patients with trauma or anxiety related diagnosis. While for others, really there's a sense of emotional or virtual distance experience with telebehavioral health that can sometimes be off-putting. So depending on the mental health conditions or substance use conditions, substance use disorder conditions that your patients or clients are experiencing, some may feel more comfortable with the services provided via video conferencing, where others want to be like, oh, I don't know, I just don't feel as close to the people in group or to my therapist, and I'm worried about that. So it's up to us to address those issues with our patients and clients. This is an interesting study done by Jay Shore. This was done in 2012. And he reported that many American Indian women with histories of post-traumatic stress disorder and domestic violence said that it was easier to begin working with an unknown provider over video because it provided, once again, that feeling of distance, and that distance facilitated a feeling of safety. So this is one very, very small study, but certainly that's one of the findings is that the American Indian women really, with these particular issues regarding PTSD and domestic violence, just said, hey, that's safe. That distance gave me more feelings of safety. If you look at all the studies, there's high levels of patient satisfaction. This is really consistently reported. If you look at most of the systematic reviews or the meta-analysis or any individual kinds of studies regarding the use of telebehavioral health, one of the most significant findings that you'll find is that patients like receiving services via video conferencing, and that all patients populations, children, adolescents, senior, minority populations, and individuals in the justice system also report satisfaction. So we can't separate out that, oh, this particular patient population was not satisfied with services delivered via video conferencing. In almost all the studies we see with different types of client populations, patients are reporting satisfaction. Now, a recent, not really, but a recent study came out in 2020 in August, and they found that patients participating in an online group reported feeling less connected than group members participating in in-person sessions. But most of the online group members believed or said that the convenience of attending group online offset any barriers or difficulties experienced, that they probably wouldn't have been able to attend group sessions if they didn't attend the online sessions. And while an online group was not their first choice, it was certainly preferred over no treatment. So we got to keep those things in mind. Like, man, if online counseling, mental health treatment is the only way somebody's going to get treatment services, then yes, we should make sure that we're offering quality services via telebehavioral health. Now, providers tended to express more concerns about the potentially adverse effects of video conferencing on therapeutic rapport. And so what we ended up with is having reluctant providers rather than reluctant patients. And this is something that we as clinicians have to deal with and recognize where our reluctance is coming from. In one recent study in 2020, McClellan found that clinicians' use of telebehavioral health, when they were using it, they had concerns about using new software programs or technologies, about confidentiality, privacy, and security issues. They had questions about telebehavioral health's efficacy, and they had regulatory concerns. Uncertainty about laws governing telehealth or roadblocks, and maybe many of you have those same concerns. So another study done in 2018 went on to say that telebehavioral health does change how a clinician provides services, with most of the burden being on the clinician rather than the patient. So let's think about that for a minute. When I'm a clinician and I'm providing treatment services, I might have to drive a ways to my clinic. But once I'm at the clinic, I see patients. And then and I provide most of my services on site unless I'm doing home visits and those type of things. But for many clinicians, when providing mental health or substance use disorder treatment services, the patient is the one who has to do more of the work, meaning they got to figure out how to get to the clinic, who's going to babysit, how they're going to get a ride, how they're going to get a ride home, how are they going to miss work. Whereas clinicians who are providing services via telehealth have to set up the session. They have to make sure they have a good connection. They have to make sure their client has a private and secure area, that the client's not having any technology difficulties. Lots of different things in the preparation to seeing a patient for clinicians providing services via telebehavioral health that they don't have to take into consideration when providing or seeing a patient in person. So one of the things, this comes from Battistini's most recent study, and she says, you know, we know that clinicians have been worried about building therapeutic rapport, but she said she has found that her clinicians in providing mental health services to folks who are in jails or prison, her clinicians have been able to project a stance of openness, interest, inquisitiveness. They've been able to, through like exaggerated postures, and we'll be talking about some of those tips and things of what you have to do about being on camera. And they've been able to do thoughtful inflections when speaking in virtual sessions, and clinicians have been able to introduce humor, direct therapeutic challenges, and use motivational techniques such as rolling with resistance. So they've been able to do their job via video conferencing. Okay, they might have to do it a little bit differently, and we'll talk about that in a minute, but they've been able to do that. McClellan also went on to find that that he did a study regarding clinicians' attitudes about telebehavioral health, and clinicians with more telebehavioral health knowledge, not surprising, and experience tended to have more favorable opinions. And so what we need to do is increase knowledge and promote skill proficiency, which may help with creating positive attitudes towards the use of telehealth. And also, McClellan describes it as being a key to widespread adoption, and that practice with feedback, observing colleagues, and accessing experts really help to build clinicians' competencies and their comfort level with using telebehavioral health. The other thing we're looking at here is that making sure, or one of the ways to promote adoption of telebehavioral health at your agency is to develop or define a champion. And so clinicians who are champions of telebehavioral health can serve as strong advocates, all right? And they can do that by convincing staff members of the value and utility of delivering services virtually. They can bring legitimacy and credibility. And when you think about it, you always have a couple of go-to people at your agency. And those are the folks that people listen to. They're really maybe the silent leaders. And if you can get their buy-in regarding the use of telehealth, the adoption by other practitioners or clinicians at your agency is going to increase, because they will help use their relationships to promote the adoption, hopefully leading to implementation. So let's look at telebehavioral health guidelines and tips, all right? And there are guidelines out there. And in fact, in 2013, the original guidelines for providing services, mental health services virtually when it were created by the American Telemedicine Association in 2013. And then in 2018, the American Telemedicine Association worked in collaboration with the American Psychiatric Association, and they revised these guidelines. And so these best practices and guidelines are available. You can download them easily. When you get a copy of the presentation, it has the URL address and how to access it. But in these guidelines, there's 4 areas that are covered in good detail, actually. Legal and regulatory issues, standard operating procedures, technical considerations, and clinical considerations, right? And then recently, the American Psychological Association came up with a document and some general guidelines about how to do group therapy using telehealth. And these guidelines are not as extensive as the ATA and APA guidelines, but they are available. So here's some tips regarding how to do video conferencing. These are tips for clinicians. And you can pass some of these on to your patients and clients as well. But do look directly into the camera rather than looking at the picture of the person on the screen, so you get this sort of pseudo eye contact. Certainly balance facilitative and directive language. So you would say things like, what are your thoughts about the next steps you might take? So more of a clinical, facilitative statement. And then you might be more directive later on in your session by saying things like, it sounds like you have a lot of background noise going on. Can you move to a different spot for our session? Is that possible? And so, which is a little bit different for some clinicians to match facilitative language with directive language. And 2 of our video conferencing experts talk about that you have to be the driver of the bus. You are the person that is in charge, and that you're going to be more directive than you're used to being when you're doing in-person sessions. Make sure you wear solid colors and dress, and then dress as if you're going to work in the office and in the clinic. Be really careful about dressing too casually. Nod your head and lean forward. Make sure your face takes up about 2/3 of the screen. This is always worrisome for me, but certainly you want people to be able to see you and to be able to see your reactions. And the therapist's reactions are really important part of doing counseling and providing empathy and support. Act slightly more animated. Stay seated, don't pace, sit up straight. Sounds kind of like my mom, but that's good advice. Adjust the camera so your entire face is visible and facing forward. None of these side shots. Certainly avoid fidgeting, tapping, and doodling. Any kind of distracting behavior is really important to avoid. Eating or drinking during sessions. If you need to take a sip of water, just turn your head away from the camera. Make sure you don't participate in any kind of video camera shaming. In other words, demanding that a patient or a client turn on their camera. We have to be very respectful. Remember that we're coming into people's homes or coming into their private areas, and we want to, and that's new for us, and we have to make sure that some patients may and clients may have some embarrassment about their home or about the status of their home. And so if they're unable to turn on their camera, we should be accepting of that and not demand that they have their camera on. And watch out for making exaggerating motions with the hands. One of the things I have to be careful of. Now, when you set up your office space, make sure you remove all distractions. You don't want patients or clients focused on trying to figure out what's on your bookshelf behind you. I always, when I'm watching some kind of newscast where the person's broadcasting from home, I'm like, oh, what's on their bookshelf? Oh, is that a picture of their family? And then I miss everything that they've just reported on. Ensure there's good lighting so there's no shadowed faces or halo effect. Provide a private and clean looking space. Aim for a neutral backdrop. Don't sit with a window behind you because that can cast shadows. And ensure good placement of camera, microphone, and speakers. And remove any Alexa type devices. We hadn't even thought about this, but in working with some of our experts, one of the things they discovered is one of their clinicians had Alexa on while they were doing the session, and Alexa started repeating some things. And I was like, oh my gosh, you've got to make sure that all those type of devices are turned off. And also ask the patient or client if they have those devices to turn those devices off. And then make sure you put up a do not disturb sign on your door. Put up a sign that says in session from this time to this time, so that people know not to knock on your door, whether you're working at home or whether you're working at your agency. It's really good to have that information on your door so that your sessions are not interrupted. And then this is not a picture of me, but we have to be really careful about being too casual. I'm going to talk about that in just a minute when we're providing services via video conferencing. So our role as the clinician, or one of our roles as the clinician, is to serve as a role model. And so we need to turn off our phone and our email, not to be distracted during session. We should use a virtual waiting room, but not keep people in there forever and make, just like we do in person. We don't keep people waiting a long time in our waiting room at our clinics. Same kind of thing. If we're providing services virtually, we need to be on time. Being online can cause people to act more casually. It's a true thing. It's called the disinhibition effect. We also have it not only with video conferencing, but we have it with social media and social networking sites. People tend to disclose stuff that they wouldn't normally do if they're in person. So make sure and track your self-disclosures and limit those and watch out for chatting, and make sure that you follow like the 90-10 rule. So 90% of the time you're doing counseling, and 10% of the time at the beginning and at the end of the sessions, you're doing engagement, how you doing, good to see you, those type of things. And you know, the rest of the time you should be doing your work, because it is a work situation with your client or with your patient. And make sure that you maintain those boundaries, reminding yourself and them that this is a counseling session. It's not a casual virtual meeting with friends. And several of our experts talked to us about some of the trouble that their clinicians have run into with, oh, is that a picture, you know, of patients saying when their clinician is providing services from their home, and the patient's, oh, is that a picture of your husband? Oh, I hear a dog. What kind of dog do you have? And that they end up doing all this sort of like friend or casual behaviors rather than keeping it much more clinical and on the level that you're supposed to do regarding a session. Now, we're not talking about being cold or remote or aloof. We're talking about being careful because the technology causes us to be more casual, and we're just making folks aware of that. And then when we look at ethical duties, you know, one of the things that we keep seeing in the ethical competencies that like the American Association of Marriage and Family Therapists, American Psychologists Association, National Association of Social Workers. If we start looking at their ethical codes, one of the themes that we see is that clinicians have to demonstrate competency with the technology. So minimally, clinicians and counselors using video conferencing platform should be able to show their capacity to use the technology with basic skills and be able to troubleshoot problems. And we're not talking about clinicians being like IT experts, but we have to be able to use our own technology in a competent manner, as well as be able to help patients troubleshoot their tech problems with technology. And that comes from just practice and more use and practicing with colleagues. Okay, so specifically, clinicians and counselors should be able to do the following when delivering services virtually. They should be able to advise and help patients with the use of the selected technology platform, should be able to explain the reasons for their choice of the technology platform. Like we at our agency have decided to use Zoom as a platform because it's ease of use, its affordability, its functionality, its privacy and security, and its adherence to federal confidentiality, 42 CFR Part 2, that's for substance use disorders treatment. You should be able to explain to patients the tenets of informed consent specific to behavioral health. You should be able to translate your clinical skills to provide services virtually, right? And you should be able to determine which patients and clients should and should not receive services using video conferencing. This is almost like a checklist. If you are a clinical supervisor and going through and saying, hey, is my clinician ready to provide services virtually? Can they do these things? Okay. Also then for clinicians, we need to ask ourselves, just because I can use these are some questions we should ask ourselves. So let me start with the first one. Just because I can use telebehavioral health to conduct counseling and treatment sessions, should I? Do I have the training that I need? Do I have supervision? Do I have access to people who can help me out? What's my level of competence? Am I a beginner? Am I a master's level? Do I need more training, supervision? Does my practice or organization adhere to any specific telebehavioral health guidelines? And what do my state board regulations say about conducting telebehavioral health? Am I in compliance with my state board? So what we're seeing now is most agencies and clinics are developing policies and guidelines for their clinicians regarding providing virtual service delivery. And if you don't have those in place yet, you can look at those guidelines that I went over by the ATA and APA, and then you can start looking at what are maybe some of the best practices that are out there to provide services. So let me move into another category here. And this is talking about ensuring privacy, security, and confidentiality. And obviously you would develop policies and practices around that as well. So we're going to be talking briefly, this is like a very large overview regarding privacy, security, and confidentiality. So when you hear me saying HIPAA, I'm going to say HIPAA secure, not HIPAA compliant, because that's a misnomer. It's not the equipment that is HIPAA compliant. Equipment is HIPAA secure. Professionals make the equipment HIPAA compliant. And what do we mean by that? Well, if you look at the HIPAA rules and regulations, basically it says that each entity or provider has to do an assessment of their service delivery, and they have to assess their service delivery to make sure that they are meeting all of the requirements regarding HIPAA, and that they've chosen the proper equipment. They've put practices and policies in place. They've provided training for their staff. They have ways to solve problems regarding privacy and security issues. And so when we think about using a video conferencing platform, don't just go with, oh yeah, this company says, this vendor says that this platform is HIPAA compliant. It's not. It's HIPAA secure, and that professionals, it's the people that work at the clinic that really make the platform, whatever platform you choose, to be HIPAA compliant. But there are some things that, due to the public health emergency, that the Office of Civil Rights has done during this time. And a couple things that they have done is that they have waived potential penalties for violations, HIPAA violations, arising out of good faith use of telehealth. Now what does that mean? And this is really an important tenet. We can't have people going, oh yeah, I just went out and used whatever platform or whatever equipment, and I didn't check into things, and my patient's privacy and security was violated. And so what we have to look at is good faith. I made a good faith effort to put the protections into place, and I didn't purposely go out and violate any patient's privacy and security needs. And so the Office for Civil Rights has, during the public health emergency, which is still in effect, allows practitioners to use non-public facing remote communication products. And these non-public facing remote communication products include Apple FaceTime, Facebook Messenger video chat, Google Hangouts video, WhatsApp video chat, Zoom, and Skype. And sometimes some of these video conferencing platforms would not be approved if it wasn't during the public health emergency. However, the Office for Civil Rights says you can't use, even during the public health emergency, you can't use these public facing platforms. And so here's some examples of these public facing platforms. TikTok, Facebook Live, Twitch, and Slack are just 4 examples. And so these should not be used to deliver services using video conferencing. All right. Now, you should use video conferencing platforms with end-to-end encryption. And you say to yourself, oh my gosh, Nancy, what does that mean? Basically, it means that communication is protected while it's transferred from one end system, excuse me, or device, from one end system or device to another, so that we have end-to-end encryption, meaning that both from the provider to whoever's receiving the information or the services. And that's number one. Number two, video conferencing platform vendors should be willing to sign business associate agreement. So if you are looking into which video conferencing platform you should purchase, you can ask 2 questions. 1, do you have end-to-end encryption? And 2, is your company willing to sign a business associate agreement? Some examples of video conferencing platforms that have both of these and that people are using, many clinicians are using, is Doxime, Zoom, VC, ClockTree, Microsoft Teams, GoToMeeting, Skype for Business, Cisco, WebEx, EasyTalk, Starleaf. These are just examples. I don't own stock in any of these companies, but part of what HIPAA and the Office for Civil Rights, or excuse me, the Office for Civil Rights will look at is what's your good faith? Did you make good faith efforts to investigate which platform is the best, which platform provides the best protection, which platform can you afford as well? And remember, we talked about at the very beginning of this, it's not the platform that's HIPAA compliant, it's HIPAA secure, and then the agency or the clinician will ensure that it meets all the conditions of HIPAA. Now, we get a lot of questions about the use of telephone and texting. Also, the public or the Office for Civil Rights also said, okay, we're going to allow the use of telephone. And then CMS, which is Medicare and Medicaid, said, yes, we'll approve the use of telephone. And then as of July 23rd, all 50 states, their Medicaid agencies and Washington, D.C. have issued guidance to allow for a form of audio-only telehealth service delivery. We don't know how long that's going to be in effect, but right now it's allowed and it is billable. When we look at texting, that's another issue. There are texting apps out there. Examples of some are Signal, Jabber, Facebook Messenger, Google Hangouts, WhatsApp, or iMessage. And once again, most of these systems are more like using, and you have to have access to the internet, and it's like using a HIPAA secure email messaging system. Texting patients using regular cell phone, from cell phone to cell phone, not using any of these closed systems, should not be done. And even though we know that some clients really expect or are asking providers to, oh, just text me on my cell phone. And we also know that a lot of patients don't have access to the internet, and so it would be difficult to they could not use one of these HIPAA secure text messaging systems. So it's really, there's lots of novel ethical concerns involved with texting patients from your either work or personal cell phone to their personal cell phone. This particular webinar won't get into the details, but there are some issues. Just to give you one example quickly. So, you know, you don't know if you're texting a client if someone else is going to read that message. You don't know if the message you receive from a client supposedly is really from a client or someone else sent it from their phone. So all sorts of ethical and legal and privacy and security and confidentiality issues that put people at risk, both the clinician and the client and the patient, if we're using SMS texting. So I told you it was going to be a whirlwind view of many of the topics and the research and tips. But now I'm going to go over some resources that provide a lot more detail and that you can easily access to get more information. So the ATTC, excuse me, the ATTC and the MHTTC network coordinating offices, there are telehealth learning series, there's telehealth products. The Mountain Plains ATTC has recorded webinars and audio consultation sessions, and there's a Center of Excellence on PHI, private health information, that's funded by SAMHSA. Let me show you those quickly. This is responding to the COVID-19 and then using telehealth. This is on the MHTTC website, and you can see the URL addresses below. This is the telehealth learning series. This is an audio sessions that you can listen to, sponsored by the ATTC National Network Coordinating Office. There's also a telehealth learning series and frequently asked questions that you can review. And then the Mountain Plains ATTC that I work with has tips for using video conferencing. This is a webinar that we did early in the pandemic, like March 27th, to try and help folks. You can download and watch or listen to this recording, this webinar. And then we have 11 different sessions, audio consultation sessions that you can listen to on different topics. And you can see there's our URL address there. And then there's the Center of Excellence for Private Health Information. And this is a SAMHSA funded center. And they have got some great resources. Let me show you two of them. One is they have tips for patients on regarding how to keep their telehealth visits private. These are tip sheets that you can download and give to patients. And in fact, we know of at least 2 treatment centers that are, and there's probably a lot more, that are downloading and printing these tips and having them available for patients, or they download them as PDFs and then send them out to patients for their review through email. They also go through some of these during sessions with patients. And then this is, excuse me for a minute, this is tips for counselors, both mental health and SUD providers. So let's look at the future. So providers really are waiting to see how the post-pandemic regulatory and policy landscape shakes out. What are the emergency, what's going to happen? What if the emergency measures expire? What actions will state and federal regulators do regarding telehealth? Will CMS continue to support remote patient monitoring programs and allow the patient's home to serve as a telehealth site? Will privacy and security guidelines, most notably HIPAA, be revised to allow providers and patients to connect on more platforms, including audio only, like phone? Will reliable broadband become a reality? And then the longer the this is from a video conferencing expert, Dr. Jay Shore. These are some of his predictions. He believes that the longer the pandemic and associated quarantines continue, more likely the current changes will become solidified and become part of our routine in the practice of behavioral health, which might be the only good news if the pandemic lasts longer. If the pandemic is controlled, will current regulatory and structural changes stay in place or revert back? And what if the pandemic becomes episodic, and so resulting in a series of sporadic and regional quarantines? What will happen? Will there be state or region specific regulatory and structural changes? And what will the lessons be of the COVID-19 pandemic? What services should be done in person or through telehealth or through other technologies? Okay. And let me give you a summary statement here. So in case people say to you, what'd you learn today? So hopefully you learned that telebehavioral health is equivalent to in-person care, that the research base on mental health services is extensive. The research base for substance use disorder treatment is growing, especially regarding opioid use treatment, that patients express satisfaction with it, they like it, that clinicians initially may be reluctant, but once they get more training and practice and build their competency, that reluctance seems to go away. that there's national guidelines and tips available that you can access, and that you and your agency can help. You can use these guidelines and tips to help build your policies and procedures, that there are resources and technical assistance available that you can access really easily and that are free. And that what is telehealth going to look like post-pandemic? And basically, what we can say is that we think that we're going to have more of a focus on a hybrid patient, meaning that we're going to provide some services online, some services in person. We might start to use, we might do telephone to do quick check-ins or consults or actual sessions. And then we also will be maybe using more different types of technology like apps or like wearables. So this may lead us to really having sort of this virtual service delivery that includes lots of different uses of technology. So I was happy to talk with you today. Once again, my name is Nancy Roget, and this is my contact. This slide has my contact information. You can always reach me through email, and I want to thank the folks today for inviting me to present. And I'm just really excited about all the neat things that are happening with the use of video conferencing or telebehavioral health during this very serious time where we're trying to, where providers like you all are still trying to provide treatment services, even in the middle of a terrible public health emergency. Thank you for this opportunity.